Welcome to this explainer. Look, if you're a medical student, a nursing student, or a surgical resident, you already know you spend a massive chunk of your time on the wards managing surgical drains. They are literally everywhere. But what actually happens when we fundamentally misunderstand these essential everyday tools? Well, today we're going to master surgical drains. We'll be looking at the mechanics, the daily management, and the hidden dangers of the plastic tubes we rely on every single day. So let's just dive right in.
I want to hook you right away with a classic 2 a.m. clinical puzzle. Picture this. You have a 58-year-old patient who just had a laparoscopic distal pancreatectomy. Out of nowhere, he starts crashing. He's spiking a fever, he's tachycardic, and he has localized peritonitis. But you check his intra-abdominal drain, and it shows a perfectly clean, totally reassuring 15 milliliters of output. The math isn't mathing, right? And then, a stat point-of-care ultrasound reveals a massive 350 milliliter fluid collection hiding right near the pancreatic stump. So, how in the world did this happen?
Well, the crucial point here is that surgical drains represent this massive clinical paradox. Now, when they're managed perfectly, they are absolutely invaluable for decompressing dead space and alerting us to occult leaks. But an ill-chosen or mismanaged drain, it isn't just a passive piece of plastic. It acts as a false security blanket. And even worse, it can actually be a vector for ascending sepsis or a direct cause of tissue breakdown if you don't fully understand the physical science behind it.
To make sure you never get fooled by a drain on your ward rounds, here's our roadmap for today's explainer. We'll cover 1. The post-op drain mystery, 2. How drains actually work, 3. Types of surgical drains, 4. Daily ward management protocol, and 5. Bedside wisdom. All right, kicking things off with Section 1, the post-op drain mystery, and why 15 milliliters isn't always what it seems.
Let's look a little closer at this specific, deceptive clinical data that completely lulled the surgical team into a false sense of security. It's post-op day 5. The patient is showing the absolute classic signs of a major complication. The resident looks at that 15 milliliters of serosanguineous fluid and, understandably, reassures the team that the operative bed is clean. But then that stat ultrasound proves the drain has entirely failed to evacuate a 350 milliliter abscess. To understand exactly why this drain failed our patient, we really have to go back to basic physics.
And that brings us perfectly to Section 2, how drains actually work, bringing physics straight to the bedside.
For a fantastic conceptual analogy, imagine a basement that's prone to flooding. An active closed drain is kind of like an automated sump pump. It uses continuous negative pressure to actively draw fluid out into a sealed bucket, which completely prevents external debris from getting back in. On the other hand, an open passive drain is basically like dropping a leaky, perforated garden hose into a muddy ditch. It relies purely on gravity and capillary action. So if the floodwaters outside rise, contaminated water can literally run straight back down the hose and right into your patient.
Because at the end of the day, surgical drainage isn't magic. It is governed purely by fluid dynamics, specifically a little something called Poiseuille's law. This physical principle basically states that the volumetric flow rate of laminar fluid through a tube is proportional to the fourth power of that tube's internal radius. Now, I know that sounds like dry textbook stuff, but this math has absolutely terrifying clinical implications on the ward. Because flow rate is proportional to the fourth power of the radius, think about what that means in practice. If you have even minor fibrinous clogging inside the tube, let's say just enough to half its effective internal radius, you don't just lose half your flow, no way. You destroy 93.75% of your drain's flow capacity. Almost 94% of its function is just instantly gone, all from a tiny bit of internal sludge.
And this physical reality directly dictates the materials we use. We essentially rely on two main types. Inert materials, like silicone and polyurethane, are highly biocompatible. They evoke minimal inflammatory response, which makes them absolutely perfect for delicate tissues, like plastic flaps or a pancreatic bed. Conversely, irritant materials, like latex and red rubber, are designed to intentionally provoke the body. They induce this intense inflammatory response so the host tissue walls off the tube and forms a mature, fibrous sinus tract. You absolutely have to know which one is sitting inside your patient.
Moving right along into Section 3, types of surgical drains. Let's organize the tools in our ward arsenal.
As a student or resident, you really need a mental framework to categorize every single drain you see on morning rounds. This matrix is perfect for that. You can break them down into open versus closed systems and passive versus active mechanisms. For instance, a Penrose drain, that's open and passive. A Jackson Pratt or JP drain is closed and active. And an underwater chest seal is closed but passive.
Memorize this grid, and I promise you'll never be confused during handover again.
Now, we have specific indications and major risks for each of these common drains. Take the Penrose, for example. It relies on atmospheric zero-pressure capillary action. That makes it great for superficial abscesses, but terrible for deep spaces because of the massive risk of ascending infection. Now, compare that to the Hemovac, which is an active, closed suction drain delivering high suction at -80 to 100 millimeters of mercury. If you put a Hemovac directly against a fragile, newly created intestinal anastomosis, that massive vacuum can literally pull the bowel wall right into the drain's perforations, causing suction necrosis and a fistula. The tool absolutely must match the tissue.
Next up, Section 4, Daily Ward Management Protocol. This is exactly how we manage the life cycle of a drain on the floor.
All right, here's your 5-step daily mental checklist. Step 1, insertion. A drain must never, ever come through the primary surgical wound line. It needs a separate dependent stab incision to prevent wound breakdown. Step 2 is fixation, usually using a Roman sandal tie. Step 3 is maintenance. Remember that 94% flow loss from clogging we talked about? Yeah, that's exactly why you must strip or milk the tubing every 8 hours to prevent fibrin clots. Step 4 is stratification. And finally, Step 5 is safe removal.
But how do you actually know when it's time to pull it? Well, you use hard biochemical numbers. The quantitative trigger for removal is usually when output falls below 25 to 30 milliliters per 24 hours for 2 consecutive days, and the fluid transitions to being strictly serous. But you've got to pay attention to the diagnostic assays. If the effluent suddenly turns turbid or milky, you test it. If the drain fluid amylase is greater than 3 times the upper limit of normal, you've got a pancreatic leak. If the bilirubin is greater than 3 times normal, you're looking at a bile leak.
Now, here is a revelation that actually surprises a lot of junior clinicians. Major international guidelines, like ERAS for colorectal surgery or the World Society of Emergency Surgery, actually strongly advise against routine prophylactic drainage in many cases. And why is that? Because the evidence shows that routinely placing drains doesn't always reduce leak rates, but it absolutely does increase patient pain, impair mobilization, and prolong hospital stays. Sometimes, completely omitting the drain is the safest possible route for your patient.
Finally, let's wrap things up with Section 5, Bedside Wisdom, featuring a few vital pearls passed down from senior attendings.
Here's your very first golden rule, the vacuum venting rule. Never, ever extract an active suction drain while it is charged under vacuum. Think about it. If a JP or a Hemovac is actively sucking and you yank it out of the patient, that live vacuum can shear the mesentery, rupture fresh capillary beds, and cause severe, completely unnecessary pain. Always, always unplug the bulb or open the port to release that negative pressure before you pull.
The second pearl is the 10 to 14-day T-tube rule. Earlier, we learned that latex is an irritant material, right? It's literally meant to incite a fibrous tract. If you pull a latex T-tube from the common bile duct before that dense, mature tract has had a full 10 to 14 days to fully form, free bile will spill straight into the unsealed peritoneal cavity. You will cause a catastrophic biliary peritonitis. Patience is literally life-saving here.
And this brings us right back to our initial 2 a.m. mystery. Remember? Our patient had a massive 350 milliliter abscess, but his drain only showed 15 milliliters. This, my friends, is the sentry drain delusion. We cannot rely on a drain to permanently protect an anastomosis, because the body's omentum and surrounding viscera are incredibly smart. They will quickly wall off that foreign plastic drain within 48 hours. A drain can be completely dry, walled off in its own little cocoon, while a life-threatening localized abscess develops just 2 centimeters away. So, as we conclude this explainer, I want to leave you with a slightly provocative thought. Next time you step onto the surgical ward and check a drain during morning rounds, I want you to look closely at it. Ask yourself, is this tube actively protecting your patient right now, or is it just giving you a false sense of security? Thank you so much for joining me. Keep questioning everything you see on the wards, and I'll see you in the next explainer.